Today we want to cover the issue of surveillance, address the issue of, we've been at this for over a year now, the fatigue part of it, not fatigue from the infection, but fatigue from dealing with the pandemic. And then to look at quality improvement, which is missing an E. I just noticed that. So this is a shortened version of improvement. All right, next slide, please. So our learning objectives is to develop a method to disseminate updated information on COVID to the staff, as well as to family members, I might add. We want to define screening practices within the nursing home. And if you have not had a chance, it would be good to take a look at the CMS toolkit, which has just now been updated in March 2021. That talks about the different strategies that nursing homes from each state have developed. And I'll share some of those best practices with you. And then the third point here is to look at the challenges and possible solutions to the whole issue of fatigue that's besetting us, particularly with the wearing. Next slide, please. So we know that this is a balancing act. We've got CMS guidelines, we've got CDC, we've got EPA, we got OSHA. I always comment that next to nuclear power plants, nursing homes are the most regulated industry in the entire world. That is a formidable challenge, and we need to constantly be on our guard for fatigue about all these different following all these guidelines and trying to stay up to date as much as possible. That's in part what this is supposed to do, is to provide ongoing newsletters, weekly debriefings, and so there's different strategies across the country. So I made a reference to the CMS toolkit. The update now, I did not update the slide, but it is updated as of March 1st, 2021. And so they added some of the guidance related to visitation recommendations, as well as some changes related to how to handle staff who have been vaccinated but been exposed to COVID. Okay, next slide. CMS provides podcasts twice monthly. So if you tune in to those will give you updates. They tend to be a little bulky. I'm not particularly a big fan of them. I listened to them for a while and then kind of just faded, but they are available, and they archive them so you can go back and listen to some things. We talked to Thrifty White Pharmacy Services, and we thank them for their rolling out the vaccines. Apparently, they've got over 80% of residents vaccinated throughout the states here, and we're close to 60% with our staff, which is pretty good. I mean, compared to Illinois is only 40% as of today. So congratulations to the facilities for getting that many staff vaccinated, and hopefully we can get a few more. I just put in what the CMS reimbursement is for the vaccinations, just to give you an idea. It's interesting because the cost of a COVID test in London, where my daughter is 150 pounds, which that would be about $175. So if you're in London and need, the COVID test, outside of their public health system, it's pretty pricey. Next slide, please. Yeah, so we want to talk about the relationship. This is just so strong. So whatever's going on in the community is what filters into the nursing home. I mean, that may seem obvious, but I think so for so long, everybody's thought of the nursing home as a place unto itself, right? These infections occur because C. difficile colitis is spread, amongst the residents, or, outbreaks of influenza are because resident to resident spread. whereas actually this pandemic has demonstrated that the portal of entry is the community. And interestingly, whereas in the beginning of the pandemic, the bulk of COVID was, COVID positive patients in long-term care were residents. But now the bulk of COVID positive individuals are staff. It's actually at this point, at least in North Dakota, to the best of my understanding, about a 5-to-1 ratio. So there's, for every 5 staff members, there's 1 patient. So that's kind of a good news, bad news situation. The good news is that the residents are being protected, is the way I interpret that. I guess the bad news is that, staff still come up, positive and still are a primary vector. So we'll talk a little bit about that. Next slide, please. So this is a case or a scenario that the CDC talks about. You can see there's a reference down there, but basically there was a wedding reception. This was in rural Maine, and you can see just how the distribution of COVID occurred. So you had 30 cases from the wedding reception of COVID, and look at the transmission going from locally, where there were 30, almost 30 more cases, and then 100 miles away, a long-term care facility, because one of the members of the wedding party had COVID, spread the case there. And then also it entered into a penitentiary. And so you can just see that, they talk about these so-called row factors. So for each infection, it's about 3 people that get subsequently infected because of COVID. So again, the idea that just to really emphasize this case report here is to avoid large gatherings, stay at home when you have symptoms, always wear a mask and social distance. And it's just really interesting. I went to Shields, to buy a present for my wife, and nobody was wearing masks. And I just I did an about face, that this whole thing of people not wearing masks anymore is just sending me for a loop. I don't understand it. Okay, next slide, please. Yeah, so these are CDC definitions about community transmission. So there's 3 levels, right? So we got the no to minimal community transmission. So those are isolated cases. Those are, in terms of our state, those would be like, the 10 to 20 cases across the state. Whereas the minimal to moderate community transmission is where you have a more sustained likelihood of transmission, and that there's confirmed exposure within communal settings. And, so the communal settings would be, long-term care facilities, as well as schools and penitentiaries. And then, the final risk level is large-scale community transmission. So that's when we recognize the percent infectivity or percent, rather the percent positive rates being 10% or greater in the testing strategy here. Next slide, please. So just kind of a little bit of a review. We've got really 2 options, right? There's the screening at the point of care. So that's the swab. They now have a saliva test, which is pretty much equivalent to the swab. And then there's the symptom-based screening. And, the problem with the symptom-based screening is, well, at least in the, as well as the temperature check, is one is that if somebody's on Motrin or, Advil or whatever, or Tylenol, they're going to suppress their temperature. If they happen to be an employee or staff member over the age of 60, they've got about a 20% chance of not developing a fever. So the temperature is not a real robust way to check for infection, but it is, it's important to do that. And then in terms of the limitations, we've got people that are totally asymptomatic, and so they say that about and depending upon age, so the younger you are, the less symptomatic you usually are. And that could be up to 20. In some cases, 30% of the people are asymptomatic carriers. And then finally, somebody might attribute their sniffles to seasonal allergies. And as we're entering into the season, we've got to really consider, is it true allergies, or is this the early onset of COVID? So I think we're kind of stuck, right? Is that just because somebody has had an allergy history, we still have to really have a high level of vigilance that those symptoms may actually be either superimposed COVID or COVID in of itself. So those are the challenges that we're facing, and we have to use our clinical judgment in our screening strategies. I always use the axiom that when in doubt, screen. Okay, next slide, please. So here we'd like you in the text box is just how do you assure staff report symptoms or exposure? So if you don't mind putting in the text box, just if you had any strategies or special methodology for self-reporting of symptoms or exposure. And if you want, you can also put in whether you have somebody actually physically screen the individual versus a paper-based, when they sign a log, so self-reporting. So if you don't mind, just put those in the chat box. Yeah, thanks, Jennifer. So yeah, usually folks don't have problems. I think one of the things that comes up repeatedly is educating people about symptoms. And just reminding them that of the overlap. So I see Eric's pointing out that we screen individuals when they come in. Staff self-report. Yeah, I've got good luck with that. If they have symptoms, they're directly assessed by the nurse. So I think that's a good methodology. Interestingly, one of the cases that came up is that they had a self-reporting log at a facility, and the log wasn't checked until the end of the day. So probably a little bit of an issue, because if you got symptoms, you got somebody working the whole day before the log is checked by the infectious control nurse, that could be a gap. So you want to evaluate that. Okay. We have all staff assessed for competency on signing off and screening. So there's always a person screening someone in taking temps. Yeah. So that's good. I think that's an effective way to do that. So you actually have somebody doing the screening, and that's the question. So just to share with you, in our clinic where I work, we were doing temperature checks on everybody coming in, and then all of a sudden, we got vaccinated and nobody's doing the temperature checks anymore. So to me, that represents a gap. All right, great. Yeah, Rhonda's saying they have a screener at the desk. That's great. Jennifer is mentioning we tell staff not to come to work with symptoms and then tell us that they have symptoms. Yeah, I think that's always a judgment call. But again, what are symptoms now, right? You've been vaccinated, and you got a runny nose, and what does that mean? Or you got a headache, right? Or a raspy throat, because you get postnasal drip from allergies. So sore throat is a symptom of COVID. So again, I think part of this is to educate people that even if you do have symptoms associated with your allergies or other conditions, that they still should be reported. Because again, I'm not sure people can always distinguish, symptoms from COVID, or particularly mild symptoms from chronic conditions. Yeah, so Kelly, thank you. Many of the facilities you work with saw a decline in resident cases when they implemented a screener. Yeah, to be emphasized. So if you don't have a screener, I think that's the general consensus. I haven't seen any studies on that, Kelly, but I think that is the general impression, is to have somebody physically screen people is much more effective. So do you want to comment on that, Kelly? Any other thoughts?
No, we just did have quite a few facilities who had seen a spike in cases. And when we were going through what is your screening protocol and your process, most of them had a questionnaire type form. Whenever the staff came in at the front entrance, they'd fill out their questionnaire and then go on about their day. And once they actually had someone there doing an interview basically with them to really dig down into some of their responses, they found that they were able to catch more folks at the door before they actually came in. We had, for example, there was one, the guy said, "Oh, well, I just got my flu shot. It's just a reaction to my flu shot." And the screener's like, "No, let's go ahead and go get tested." And sure enough, he was positive. And I think another one's just tried to blame it on, the normal allergies. And those are the types of things that they were trying to use another excuse, but the screener was able to catch them.
Yeah. Yeah. Very good. Yeah, and I think Jennifer's kind of pointing out that it's hard to have a screener from 4 a.m. to 10 p.m. or whatever the different shifts are. So I mean, it's understood. It's just again, these are risk mitigating strategies. So the screener at the door. So there's a California facility, for example, that had because of the weather, obviously, they had the screening outdoors. And then they had a wash station where once you got screened, then you sanitized your hands. You already had the mask on, and then they put the gowns on at the same time. So there was kind of a stepwise process rather than going to, let's say, from the screening zone to, let's say, a staff, reception room or something like that. They actually structured it so that you went, step one, step two. There was also a facility in Georgia that was reporting no COVID cases since March of 2020. And we'll talk a little bit about that, but that was an example of facility having screening at the door too. All right, yeah, well, thank you for those comments. Those are all fantastic and all represent the different ways that we have to approach it according to each facility's needs. Next slide, please. So the big issue, or the conundrum, if you will, with test-based strategies is that do you do them proactively or do you use them reactively, right? You've got symptoms, I'm going to test you now, as opposed to I'm going to test you every other day or twice a week. So the reason is that the testing is more accurate than symptom screening alone. So that's why you want to have a good testing strategy. And then the other problem or the issue that testing does is that it picks up the asymptomatic individual. So that's why we continue to have testing strategies even with the vaccination. Okay, next slide, please. So the test-based screening, basically, I mentioned about that 10% cutoff, but this is something just to keep in mind. Is that if you're, again, this is based upon local county positivity rates. So what's happening in Bismarck doesn't necessarily affect what's happening in Cass County or Grand Forks County, right? So these are the, I quite honestly don't understand the monthly testing. If your county positivity rate is less than 5%, so, at least in North Dakota, we've been hovering around 5%, a little bit less. But I'm not sure. I just wanted to say that I disagree with that, but this is what the CDC recommends. So if you meet that criterion, that's meeting CDC criterion. Okay, next slide, please. So this basically is, I don't know, there's 3 different cases of how COVID spread through different nursing homes. And I don't really want to cover spilt milk because I think we all know the story of how COVID can spread very, very quickly. Again, at this point in time in the pandemic, the issue I think is more with the staff coming in with COVID than the actual spread within the facility. I think we've all done a pretty good job. We still need to be vigilant. And just to give you as an example, one facility put a big circle label on their disinfectants that said, 5 minutes. And so that meant the dwell time. So they're using that as a measure for their environmental services to remind them that's got to be on for 5 minutes. Another facility took laminated cards and did a checklist for disinfection. So, soap and water first, and then disinfectant second, and so forth. So there's different strategies that we can share about improving disinfection. Some of the other facilities were using the National Guard during the peak. They were focused on so special ops. It was kind of interesting that they were doing all the disinfections for the facilities. Okay, next slide, please.
And Dr. Juravich, this is
Yeah.
Kelly. Just to add another comment there is that, in Texas, at least, some of the visitation requirements are starting to open to a degree. And what we've been working with a lot of facilities on is now reiterating that disinfecting practice, because it may be staff that haven't been performing that duty during the pandemic, because we may have pushed it more with the housekeeping staff, for instance. But if activities are starting to do some more group type activities, or say a restorative program is opening up again and they're using those equipment, do they know how to sanitize between patients, and do they know the 12 times? So even if facilities aren't completely opening things up right now, it will be coming eventually, and make sure that all staff are familiar with those processes.
Yeah, that's a very good point. Yeah, there was another instance where a nursing facility tried to improve hand hygiene. They call it I think it was called the Secret Soap Spy, SSSS. So what they would do is that there would be a secret spy roaming around the facility with little stickers. And if they saw somebody doing a proper hand hygiene, coming in or out of the room, they would smack a sticker on them, as a winner. I don't know if they had any prizes or not, but it sounded like a pretty good little trick.
Definitely a great example of promoting that positive culture, as opposed to calling out all of those that are doing it wrong, really promoting and uplifting those that are following the process.
Yeah. I often describe the psychological study where they're trying to get baseball players to hit home runs more often. And so if they showed a video of a professional baseball player actually hitting the home run, as opposed to them, what they did when they were striking out, they found that by showing them the positive view, that they actually want to be hitting more home runs that season. So again, positive reinforcement is so much better than negative.
Absolutely. And you look at that just in your daily lives too. And I'll give a quick example. My sister and my best friend and I now share our rings on our workout watch or whatever. And so it's a motivation that we're doing something positive, and we're encouraging each other to do it as well. So it's the same concept, just applied in the nursing home.
Yeah. And I also mentioned in the chat, I don't know if this came up, but one of the facilities is using a text messaging scheme. So I'd really highly encourage text messaging amongst staff. So you can do a WhatsApp shared text group, and you can use that as a messenger, right? Or as a reminder for best practices. So if something comes up, or if you want to recognize somebody, you could use that text messaging system. Not everybody's wants their cell phone shared with all that, but again, that is a methodology that I would encourage. All right, so just get back to our presentation here. The symptom-based screening is still recommended. We've already kind of identified that there is some variation. We've got the people at the front desk screening versus those that have a diary, and all of that is based upon your facility horsepower, basically. If you have enough resources to do that. And we'll talk a little bit about 3 different strategies for screening. Okay, next slide, please. Oh, the famous sniff test. So you may have heard about this. We have 3 facilities that are enrolled in a pilot project where they're doing sniff testing at their facility. If any of you are interested in this, let us know. We're more than happy to get you the gear for doing the sniff testing. But basically, it's a entry into the facility. They do the temperature, they do the symptoms, and then they do the sniff test. The feedback thus far has been that the sniff test seems to be engaging people who have already had COVID, and they want to find out when their smell comes back. So that's been more of an uplifting feature of the sniff test, joy of work moment, as opposed to actual positive identification, because the incidence of, there was only 5 staff screened positive last week in long-term care across the entire state of North Dakota. So we're not sure that the sniff test is how effective it is, but we continue to use it and hope that it's an augmentation of that. And this, by the way, for these nursing homes that are doing that's a PIP for them, as to how to augment infection control. Okay, next slide, please. So we want to talk about the different strategies. So I think, in our chat box, we pretty much identified that. We had the, the checkpoint version, which a lot of people talked about. We have the self-service version, and then we have the lockdown version. So let's go to the next slide. Yeah, so here's the checkpoint. What I'd like is, we've been advocating photographs or taking pictures of your facility and then having people from your quality improvement reflect on that. So I just want to bring your attention to the left-hand side here. So there's some signage. Does anybody want to comment in the chat box as to whether they like that signage, or they have other things that they want to criticize it for? So if you have any thoughts about that one. And then while you're commenting on the signage, the other one is do you see any opportunity for improving infection control in the right-hand picture here? So you've got the individual wearing a mask. Are there any other environmental measures that you could put in to improve transmission of the infection? Yeah, so thanks, Eric, for your comment. Signage on the door is too busy. That was kind of my thought. It looks good, but my goodness, you got 1, 2, 3, 4, 5 things that you have to look at, and I'm just thinking, in terms of, visitors, right? So you get spouses of older adults coming in, and some of the signage may not be, the proper font size so they can read it readily. But anyways, I agree with Eric's comment. That there's a lot of busyness there.
And the temporarily restricting visitors, that's right in the lobby. So they're already in your facility by the time they see that sign. So maybe a better idea would be one of the folding posters, like in your driveway or in the front entrance, or like right outside the front door. Yeah,
exactly. Well, it's the famous foyer. I don't know if anybody's been noticing, but I'll have to share with you a secret. When I go into any building, if they have a double door foyer in there, I take a deep breath and don't breathe when I go through that foyer, even though I've got an N95 mask on. I just think these foyers are COVID collectors. But again, no proof of that. That's just my scientific guess as to what's going on. Yeah, thanks, Kelsey. For the right picture, there's no clear barrier. So plexiglass would be probably a pretty good idea. And you can see that there's ventilation up above this gentleman. So that's probably a pretty good thing. But the question is that you want to have your environmental control also talk about the plexiglass and how that might change the airflow. Would be a consideration. We'll send out a website that you can look at. It's actually from the Minnesota Department of Public Health, that talks about HVAC, and flows and how to use fresh air, as we're getting into the spring weather here, as a mitigating strategy for reducing COVID exposure. So I don't know if anybody else noticed on that right picture there, There aren't the social distancing circles or X's, so that might be another opportunity, to think about, and just in terms of design. And the other one is people are using the same pencils and pens. So there might be, it's considered a fomite, right? So you might want to have like little golf pencils or something that they keep, for themselves. They're fairly cheap. You can buy a box of 1,000 of them or whatever. All right, so Kelly, thanks. Everybody's using the same pen. And who disinfects the area between visitors, right? Yeah, so those are all good thoughts. All right, so this is considered the what I want to say, the Cadillac version of screening methodology. And we've identified areas for improvement. So congratulations to our group for those observations. That's really quite good. Okay, can we have the next slide, please? Yeah, so this one has some signage on the left side. I don't know, does anybody else see anything else wrong with this scenario? I think Eric mentioned earlier about the busyness of the signs. We've got 1, 2, 3, 4, 5 again signs, and we've got an arrow shooting up there somewhere. I don't know what the arrow means. We have an older adult with their cane as the greeter at the door, which might be of concern, to this foyer. And so I think the criticism here, this is a self-screening, facility. So there's no hand sanitizer. So as soon as you enter, right, you're grabbing the door handle, and there's no disinfectant for it after handling that. So that's a limitation here in terms of the self-screening process. All right, can we have the next slide, please? And then there's the lockdown, so knock, knock, and the triage nurse comes over and does the screening. So these are probably more for smaller facilities. Okay, next slide, please. Okay, so the important point is just as a reminder that if you have self-screening, make sure that somebody's checking the logs and that they're reporting the logs, and that they also get that everybody is complying with the sign-in, and then also if there are disclosure of symptoms, what your game plan is for that. Obviously, it's creating a culture of trust and having policies that help support the staff member who may be fearful of losing wages. If the policy is that you take sick leave and you've already used up all your sick leave. So we actually have one of our trainees in our educational program is kind of going over the sick leave version, and we need to work on that. Okay, next slide, please. So celebrating our successes. So these whiteboards are good. Somebody's a really great artist on this one. I don't know. It looks like they got Toy Story figures down at the bottom there. We had one of these whiteboards in our clinic where we're recognizing staff, and so I tend to doodle a little bit, and so I made for our nurse practitioner a cartoon of Wonder Woman. Just acknowledging, and she truly is. I mean, she single-handedly did our annual wellness exam program through the pandemic here. Okay, next slide, please. And the point that we were making earlier is about the fatigue that's going on. And again, anything we can do to celebrate and improve staff morale, either through recognition, that soap spy program. Food tends to work pretty good. We just got, what I want to say, approved for doing potluck meals back at my clinic. So we actually celebrated St. Patrick's Day with some corned beef sandwiches and cabbage, which is highly appreciated. So food goes a long way in rewarding staff and units. Okay, I think that may be the last slide there. We're going to move into, just one other side here is try to get a buddy system. If you don't have one, that's very valuable in improving staff morale and identifying, individuals for doing good work. Next slide, please. Okay, so can we move to our quality improvement group? And so we're kind of
awesome.
Taking up some time here. I apologize for that.
No worries, no worries. I have to tell you guys that that whiteboard that Dr. Juravich showed earlier, you'll hear me reference that a lot through this series because I think it is a great example of how to share with your staff positive improvements whenever you're going through any of your performance improvement projects, something that's catchy and real positive in nature. So you'll hear me reference that throughout the series. That is a great example of how to communicate those successes. But you have to make sure you update it when you do something different. I think that was always a challenge for me in the facility. Is like, wait, we got to go update that and make sure that it's current information now. So make sure you have somebody assigned to do so. All right.
Yeah, I was just going to add, sorry, Kelly, I was just going to add that those marker pens sometimes have licorice scents or other cherry scents. And so if you're the whiteboard keeper, take a sniff and see if you can smell it. If you don't, you just self-screened yourself.
There you go. There you go. There's another test. Perfect. Okay, so our case study for this week, I'm just going to read it out loud, and then I have a couple of poll questions, and I'm not sure if they're in an actual poll or if we're just going to ask them in the chat, Julie.
I do have 2 poll questions for this. So
well, when I get through with this part, we'll pop those up, and if those don't cover all the ones that I have, then I'll just ask them.
Okay, that sounds good.
Perfect, thanks. So there is an out-of-state visitor from California, and she wishes to come see her grandmother for the holidays. While she was screening at the front desk, she reports that she had COVID-19 the past summer and a negative COVID test 14 days after her symptoms resolved. She's unable to produce a copy of the test result. The screener at the facility finds that the visitor is afebrile, but note that she has a frequent and dry cough. So let's put up our poll and see what kind of responses we get on how you would address this situation. Awesome.
So this is what I have. If you want me to take it down,
Take it down. Yep. Sorry.
Okay. Yep.
Thank you. So we'll do the waterfall if that's possible. We'll just have a yes or no responses on this, but has your facility developed and implemented policies for screening staff and visitors? Yes, I see a bunch of yeses rolling in. I know that we have been in the COVID realm for a while now, so everyone should have policies. The one thing that I would make a recommendation is look at them again and make sure that they're still current and appropriate based on what's going on now, and then also refer back to CDC and CMS guidelines in your state to make sure that you're adhering to any of the changes and updates.
Yeah, Kelly, I was going to really stress that now that we've gone through the vaccination period here, the policy should be, as of March 2021, revised for screening policies based upon vaccine, because the staff who have been vaccinated, who have new symptoms, right? So particularly with fever, myalgias, and all the things that we associate, those have overlap with COVID infection. But there are some symptoms that are not vaccine related whatsoever. So if you have diarrhea, loose bowels, loss of smell, right? Those are, and we'll talk about that, but that's important in terms of your screening policies to reflect what's vaccine related, where there's overlap, and how you're going to handle those cases.
Absolutely. And something that probably wasn't on your original screening policy is asking people if they had the vaccination or not. Do you have your card to prove that you've had the vaccination? So those are things that you need to consider as we've had some changes come through related to the vaccines. And before I go to the next question, I've almost forgot to ask, can anybody tell me what's wrong with this picture of this young lady from out of state that wishes to visit? Her nose. Yes, absolutely. I think that's an easy one these days. We've heard it a bunch. Okay, now next question is, do line staff know where to find the policies for screening? And I'm going to adjust that a little bit to all staff. Do all staff have access and know where to find the screening policies? Yes, perfect. I know someone had put in chat earlier, it's difficult to be able to, or it's unrealistic to be able to have a screener for all of those hours. Well, if you don't have a screener for all of those hours, but someone comes to the front door and the housekeeper's cleaning the lobby, would she be able to know what to do or what questions to ask? And that's why I think it's very important that all staff understand the policies and where to locate them. And if you're looking at the bigger picture in nursing facilities in general, that's for all policies. Do they know where to access them or who to get to or who to talk to in order to ensure that they are providing appropriate information? And as we go through the series too, we'll talk about involving line staff in quality improvement and how them understanding the steps you take is beneficial in the long run. And then last but not least, are family members aware of the screening requirements and policies, especially as visitation and such have started opening back up. I know essential caregivers have been in there, and we have lots of yeses. Perfect. And I would also kind of test how you're communicating with your families and if they are understanding what all is being communicated or if they have access to it. For example, if you post all your communications for families on, say, Facebook or some kind of social media platform, do they have access to it? Do they have an account to even see it? And if they don't, how else are you communicating these things? Because it's great to say, hey, I have this way to communicate, but if people aren't looking at it, then it really is irrelevant. And she's not wearing her mask the correct way. Not allow visitation, absolutely. Yeah, I think it's important to be consistent with everyone who steps foot in the facility. And even though she claims that she's done that, or she has that negative test, it's still important. Ask her to leave, get an antigen test. Yeah, absolutely. And now the testing capabilities, it's much easier to get a test than it was before. So that was a great point, Erica, that people can go down to the local urgent care and get a test in order to get their results, and then they can bring that back.
Yeah, I was going to say, Kelly, that well, in our state, we've lifted the masking in public, so it's optional, and I think it's important that we're following the CDC guidelines. And so if somebody came in like this, even, we're using California, not to mash on Californians. I've got I have family out there, but I like to make fun of them. You might have some in-state people who say, we don't have to wear a mask anymore. And so it becomes an educational process that say, the facility's policy is everybody has to wear a mask, even if you're vaccinated. And you could maybe even have a paper educating them what the rationale is for that, but yeah, I think there's that halt sign there needs to be in place. The other issue that's a little bit of a challenge as we're getting towards visitations now from spouses, a lot of times the spouses are cognitively impaired themselves. And in my experience in clinic is they can't wear the mask. They're like that young lady that we saw in the picture. So how do you then, deal with that? So there might be a policy that you have to write up as to how to handle visitors who have difficulty with wearing a mask.
Yeah, absolutely. Just like everything else has happened in the past year during this pandemic, it's ever changing. And so these policies really have to be reviewed often and make sure that the staff are trained on the policies and they are comfortable with them. And I'm not going to really necessarily go through the next step, but I think as part of your policy and training your staff, do they know where the policy is? Do they know who to seek guidance from? Should they not understand it or not know what steps to take? And the other note I would have is if there was a screener at the front of your facility, that you have backup screeners. Everybody should have the basic knowledge of how the screening process goes so they can cover in a pinch, especially with the staffing challenges that you guys have all been through.
Yeah, and sorry to interject again, but it just occurred to me as we're talking about educating people, it might be good for folks to educate their staff about the CDC guidelines for visitation, particularly over the holidays. So if you're going to see family, particularly if you've been vaccinated, it's just one family unit. It's not like everybody's brothers and sisters. So these large families obviously are at play here. They don't want large gatherings. So you can do one-on-ones with family members, but not gather, 2 and 3 families together in one spot.
Yep.
Unless it's outdoors and everybody's socially distanced. So that's the recommendation. And you might just want to communicate that to your staff, because they're obviously dealing with the most vulnerable population here. Sorry for the interjection.
Oh, no, you're fine. You're fine. And I'll go fairly quickly through this section. We're going to touch on something we've already discussed before too, so it shouldn't take very long. But today we're going to talk about high-level flow charts as related to the reliable design. And if you recall, it was either last week or week before last, we talked about how do we test reliability or ensure there's reliability in your processes. You can go to the next. I think it's important to remember that whenever we set plans or processes that we want to improve, that we try to keep it as simple as possible. And the reason being is we really need to make sure that the line staff can understand what our intent is whenever we're trying to resolve something. So clearly state what you're wanting to do in 2 to 5 words. So either it's proper PPE use, prevent staff burnout, testing for COVID, et cetera. Go to the next slide. Oh, I think I missed a couple of slides. Okay, but if the, make sure that is there a flow diagram on, I printed it out. No, okay, well, just you go back to that one, that's fine. So if you think about a flow chart where you have boxes and the arrows in between those boxes, think about you want to communicate the screening process to a visitor, and then you want to screen the visitor, and then you want to act on the results. When you put it in a flow chart like that, it makes it visible for the staff. So here's what we're looking at is screening visitors. Here's our process. You put it in 3 simple steps. Now, mind you, those sub steps under that are going to be a little more detailed, but if you make a process too complex, then it may be a little more difficult for your line staff to follow that process. They've got a million other things to do, so you want to make sure that you keep it simple and to the point for them. And that goes back to whenever we do, performance improvement projects, we want to keep them small because it needs to be achievable. And if you're doing something that's very complex, then the chances of it becoming successful are less likely. So make sure that you keep it simple. If you're doing a flow chart, make it 3 to 4 boxes long, and then you can break down each of those sections as needed. But for the staff to understand, this is what we're aiming to improve. These are the 3 or 4 steps we're taking, and then move forward from there. Then once you have your process lined out, say it's those 3 or 4 boxes, then make sure that you're asking the staff those 5 questions that we discussed week before last. Who does it? When do they do it? How do they do it? Where do they do it? What do they need to do it? And make sure that they understand that this is the information that's needed. And the best thing about those 5 questions and interviewing 5 staff is because you really get a true picture of how reliable that system or training is, because those are the frontline workers. They're the most involved with it. So make sure that you're using those five attributes and that the staff are able to articulate to you what exactly the process is about. And I know I've said it 4 times, but make sure you keep it simple so it's easier to follow. And then I think we just have that one last slide there's a high level flow chart. You can see it's kind of small on here, but maybe Julie or Sarah can send this 1 page out to you guys so you have it as a reference as you're moving forward. But you want to make sure that all of your processes are reliable, and these are ways to test that. That's all I have.
Okay, great. So I'm going to do a little bit of a speed talk here so we can try and get you all out by, at least 1 o'clock-ish or so here. So next slide, please. So just some of the tips from today. You want to have a strategy, for screening staff, residents, and visitors. The COVID testing rate, so that 10% positivity rate in the community is the magic number where you have to do it twice weekly. If it's down towards 5 to 10%, then it's once weekly. And then if you do have an outbreak, however, you're required for every third day testing for 2 weeks. Okay, so that's the important caveat to that whole, PCR or Bionex testing rather. Importantly, train staff. And then what Kelly was saying is, review your training efficacy by asking 5 people what the proper screening protocols are. I mean, it may sound kind of stupid, but, again, we're getting, I shouldn't say stupid. It may seem so straightforward, but as we get people coming in, having somebody from housekeeping who's, swabbing the deck in the lobby there, maybe having them be able to recitate what the screening procedure is for somebody who's trying to get in through that front door. Wouldn't be a bad idea to see if they know what the screening procedures are. Next slide, please. Yeah, I just want to emphasize this whole conundrum. It's hard to really give you hard and fast advice other than to recognize the fact that we all have to use our clinical judgments. And so people who have been vaccinated pose an interesting issue because they can still potentially pass the virus on, even though they're asymptomatic now. And so we know what the vaccine symptoms are. You can get a low-grade fever. So a lot of times if people have not yet been vaccinated, best to vaccinate them on a Friday, or if they have a 2-day period off or a day period off, vaccinate them then if possible, and then allow that kind of symptom, for the next 24 to 40 hours to flourish. Because I say flourish because if you are having reactions to the vaccine, that is really a good sign, and that means it's working. But then you can see that the non-vaccine, you don't get coughs from the vaccine. You don't get shortness of breath. You don't get runny noses, from the vaccine. You don't get a sore throat and all these other symptoms that we can see. I've had colleagues who have gotten the vaccine. They actually were providing the vaccine, nurses and physicians who got COVID after their first vaccination. And it turned out that they had cough, they had a sore throat. Actually, one case, it was just a sore throat. Okay, so just remember this, that you have to ramp up your screening and go to that Bionex testing if somebody complains of these symptoms, even if they've been vaccinated. Next slide, please. Yeah, so clinical judgment needs to be applied if there's a fever post-vaccine. So if they happen to be at work and then the next day they got vaccinated and the next day they come in and say, I've got a temperature, you don't necessarily have to quarantine them. Again, you have to go through the whole issue of do they have additional symptoms. Okay, next slide, please. Really would like to use quality improvement to try to strengthen infection control. So look at your processes, see if there's we did a wonderful exercise by just looking at pictures. I mean, that's a quality improvement exercise that we just went through. And then the other one is to, again, what Kelly was talking about, do an assessment. So you could go around on your walk arounds, for example, and ask folks to give you 3 atypical symptoms in older adults. If they tell you delirium, falls, and anorexia or loss of appetite, they've nailed it, right? So that's another internal screen that you can do. I also mentioned the availability of the sniff test. We'll get you the gear if you want to implement that in your front screening. So that would be for people that have a entry screening person. Next slide, please. And then using the SMART acronym, as Kelly had mentioned, we want to make sure that your quality improvement project is specific. You've got data that you're going to collect from it. So like as that example, we asked 12 employees what the atypical symptoms of COVID are in older adults, and 9 out of 12 got them correct. The other 3 did not, and then we have an educational program to achieve that. Okay, next slide, please. Oh, so this is just a parting question on a 1 to 5 scale, where 5 being really confident and 1 not so confident. How confident that 100% of your staff know how to recognize atypical presentations of COVID in residents? And if you just put in the chat box just the number that you think you would guesstimate. Yeah, thanks, Erica. So you're kind of in between there. That's actually good, because your impression then sort of suggests that maybe you could do one of those surveys in a test. So just, like I say, you can use your walk rounds as a measure for asking. All right, yeah, thank you. So if people are just kind of in the midfield, so I think this really represents a good opportunity. You can either get this from the slides, the atypical manifestations, and use that as your checklist. You could distribute those to your staff and then go back and ask them as to what they recollect from that. Okay, so this is wonderful. Thank you for responding to that. So then
Dr. Jurevich, just to interject real quick, if you guys do that over the next week before our call next week, we would love to hear your results after you went through and asked those questions to the staff. And if you have put in a plan or what your process steps are after that.
Yeah, exactly. And so if you do this as a PIP, do it small, just survey 12 of your staff members, and then, come up with the numbers as to whether they, identify the atypical presentations or not. Yeah, this will be really good. So why don't we use this as our take action plan for next week, and we'll open up our next week's session with a discussion about what you guys found out, and go from there. Okay, next slide, please. So this is just, some questions that we have at large. Again, just to, everybody needs to redo their screening protocols as an update because of the vaccine. The vaccine has changed the screening protocols. And so those need to be updated. And then also, one of the questions, do you have a poster? Now this one's a little simpler. And so this is going to be more important as we start to open up the facilities to have very clear, large print signage. Okay, next slide, please. And the other points of from this presentation is that as you're doing the daily screens, that they then get reported to leadership as to what the results are. We were 100% negative today. We had 1 screen positive. So they should have those reports on a daily basis. And then as part of the quality improvement process, include visitors as well as staff and residents about ways to improve the screening. So just getting feedback from them on that, I think, is an important element for inquiring about the whole process, and certainly about the fatigue, because if somebody says, oh man, if I get this question asked one more time, I think I'm going to go jump off a cliff or something. Yeah, that's going to identify a PIP for you in terms of dealing with screening fatigue and the gaps that happen. Remember, donning and doffing PPE has about a 44% in one study failure rate over time, and it takes the repeated education to get that back to less than 10% problems. Okay, I think we're pretty close to the last question. Yeah. So these are a bunch of other questions that you can ask, and I'll just leave them there. We'll distribute these questions for you, just to reflect on your quality improvement process.